Chapter 42 is nursing care of the child with an alteration in bowel elimination and GI disorders. In this chapter, we're going to talk a little bit about the differences in the anatomy and physiology of children and adults. We're going to discuss some common medical treatments and GI disorders. We're going to recognize some risk factors associated with these illnesses. We're going to talk a little bit about acute and chronic disorders and talk about some of the common ones in childhood. We're going to talk about some interventions and then the psychosocial impact of this on families. So when you start with the GI tract, we're talking about the mouth to the anus. So the mouth is going to be very highly vascular, and then children more at risk for infection because of everything they put in their mouth. Babies are born with immature GI tracts, and so there's some differences related to that. The esophagus, the lower esophageal sphincter, so LES, prevents that regurgitation of stomach contents up into the oral cavity, but it's not fully developed until 1 month. So infants below that often spit up. If there's any edema or swelling of the esophagus, they can have dysphagia, so painful swallowing. Newborns have very small stomachs, so that comes into play a little bit with medications, giving them to infants because their stomach is always full. Small intestine's not fully functional at birth. And then fluid and electrolyte balances, they have severe difference with adults, which causes them to become dehydrated quickly. And so maintaining that fluid and electrolyte balance is really important. Kids have a lot of insensible weight losses of fluid. So kids who have a fever are going to lose more fluid. They have a larger body surface area. Their basic metabolic rate is higher to allow for their growth, and so that accounts for more of the water loss. When we're talking about doing a health history on kids with GI disorders, because we see this a lot, we're going to do our health history, our physical exam. We're looking for color. We're looking for jaundice, pale skin, looking for signs of dehydration. Excuse me. And then we're also looking at their hydration status. So we're going to be checking the oral mucosa. Skin turgor is not as accurate in little kids because of their thin skin, but decreased crying. Also, one of the biggest ways to check hydration status in a child who's still in diapers is how many diapers have they had in the last 24 hours. We're looking at their abdomen shape, looking to see if it's bulging. We can tell if they have any fluid retention. The toddlers, as you remember, have pot-bellied abdomens, so that's a normal sign for them. Always looking at mental status. When I talked a little bit about our across-the-room look, we're looking to see if they're lethargic. Are they interacting with their family members? Are they just sluggish, just laying there? Like a 2-year-old laying in their parents' arms is a sign that they're sick. You're going to do your auscultation, your percussion, palpation. One of the biggest things is rebound tenderness. We're looking, so that's pain when you apply pressure, and then when you release, the pain is worse. So we see that in appendicitis. Stool specimens, we collect stool specimens. If a child has a diaper, we can still collect it on page 1584 and table 42.1. There's a little teaching guidelines on collecting those stools. If they go and it's loose enough in a diaper, we can scrape it with a tongue depressor and then put it in a cup. Otherwise, we'll have them go into one of those hats that fit in the toilet, and then we'll be able to collect the stool specimen. Often kids with diarrhea, we're looking to see if it's some type of infection like salmonella, parasites, things like that. Oops, so I have a blank slide. We'll go to the next one. So anomalies of the GI tract. We're going to start with the cleft lip and cleft palate. If you notice that a lot of the subjects or topics in the book I don't go over, because a lot of them we see in adults too. So the ones you're going to be responsible for this chapter would be the ones that are on the PowerPoint. So cleft lip, cleft palate. So it's the most common craniofacial anomaly that we see. Sometimes kids have both the cleft lip and the cleft palate, or it can be they can be one or the other. It has been also seen with other anomalies. Usually, it's if a child has a congenital anomaly, there's often more. So kids with cleft lip or cleft palate, one of the biggest things is feeding difficulties, speech development, and then otitis media. Otitis media we would see if there is a cleft palate because the fluid builds up in the middle ear. It happens early in pregnancy. They don't really know why, but they feel like the risk factors are the maternal smoking, if the mom has a prenatal infection, advanced maternal age, or use of certain medications. And then usually the specialist will take care of them. Repairing a cleft lip and cleft palate is important because the child's going to have some nutritional problems if not. If you can see in the picture, the baby with a cleft lip would not be able to make a seal around the nipple or a bottle. A cleft palate is an abnormal opening into the palate. If they were fed any formula or breast milk, that is going to come right out their nose, and they could have a chance of aspirating. So cleft lip, cleft palate repair is very important that they start that early. The kids sometimes will have to have a feeding tube until that is repaired for their nutritional status. Again, if it's unrepaired cleft palate, they could have aspiration. This is a hard thing for a parent. Sometimes they can see the cleft lip in utero, but the cleft palate is not as easily viewed, so it's very frightening to them. But letting them know that these can be repaired, and getting them in touch with other resources like support groups for this anomaly can help them. Some of the GI disorders that we talk about with kids that we're really worried about is dehydration, vomiting, and diarrhea. So they can't compensate very much. They have they're more at risk for hypovolemic shock. They can be dehydrated very, very early on. A couple poops, a couple throw-ups, and they are already dehydrated. So we don't want to ever get to the point where they are going into hypovolemic shock because they can deteriorate very, very quickly. So we want to be able to address that. We want to get fluid back into them. So we'll try Pedialyte, Empholite, any of those. We will look at oral rehydration therapy. And on page 1592, there's a little box that talks about oral rehydration. Not appropriate to give them tap water, milk, fruit juice, soup, or anything like that. You really want to stick with some type of Pedialyte, Empholite, something like that. We do fluid resuscitation with IV fluids, which you learn that chart. Vomiting. So vomiting is often a symptom of other conditions, but vomiting is another area that is very concerning to infants because they can become dehydrated so quickly. Remember that their stomachs, they only hold about 10 to 20 mils. Sometimes kids will vomit because they're being overfed. And sometimes they can have some type of, illness, GI illness or something like that, virus. They will give them antiemetics to control the vomiting. and then watch that fluid intake. So really important. Diarrhea. So it's really a lot of the reasons kids come to the hospital or doctor's office. It's usually caused by a virus. Could be bacterial, but usually viral. And the biggest thing with diarrhea, again, is maintaining that fluid balance and nutrition. So we were seeing a lot of diarrhea caused by rotavirus in the daycares, but now there's a vaccination for rotavirus. So there has been a decreased incident of it. But for a while, that was the highest diarrhea from rotavirus is one of the highest rates of mortality and morbidity in kids. Some of the ways kids get dehydrated besides the GI bug is just not drinking or eating. If they have a high fever, a lot of insensible fluid loss that can be associated with some diarrhea. Obviously, diabetic ketoacidosis, and then burns. Burns, they lose a lot of fluid and they can become very dehydrated. We're going to go over a couple of the acute GI disorders that we that are more commonly seen. So hypertrophic pyloric stenosis. So basically what that is just a thickening of that circular muscle of the pylorus. And so when that is narrowed, there's an obstruction of food going in. Some of the signs and symptoms are projectile vomiting. Also, you can feel an olive-shaped mass where the thickening of the muscle is. They have non-bilious vomiting, so it hasn't reached the stomach yet, the liver, so non-bilious. And they would do a pylorectomy to cut that muscle and relieve that obstruction. So, like I said, forceful, non-bilious vomiting, and unrelated to any position they are in feeding, as we see in like GERD. Hunger after they eat, inconsolability, weight loss could progress from, just a couple vomits to severe dehydration, lethargy. Possible family history, I have seen where like one or two kids in the family have this. Again, you can palpate that olive-shaped mass. They would do an ultrasound to view the pylorus and then surgery. So one of the basic things with this is could be your nursing diagnosis of aspiration, but also alteration in nutrition. Another condition that we see is called intussusception. It's when the bowel is telescoping on itself, causing edema and then that vascular compromise, and ultimately a partial portion of that bowel will be obstructed, or that part of the bowel could actually die. We see it mostly in younger than 2 years old, and there can be other example or the other things associated with it. But if we see a kid where we suspect intussusception, what we see is abdominal pain, drying up their knees, vomiting, diarrhea, and then one of the classic signs is currant jelly stools. So currant jelly is like a strawberry jelly without any seeds in it. And so gross blood or Hemoccult positive stools. You can sometimes also feel where the bowel is telescoped on itself, a sausage-shaped mass. And the way that we fix this is they would do a barium or air enema and try to push that bowel back into place. Sometimes that works. If it doesn't, they have to do some surgery and take that part of the bowel out. A couple other GI disorders are your malrotation, volvulus. So somewhere in the embryonic developmental stage, the intestine is abnormally attached in the mesentery narrows, and then the bowel twists on itself, as you can see in the picture. So this portion of the bowel is not getting blood supply, so you have vascular compromise. Sometimes we see bilious vomiting and then abdominal pain and could have signs of shock. They're going to do surgery. They try to untwist the bowel. If they aren't able to do that, then they may do an ostomy if necrosis is in place. So they would do some x-rays to review this, and then they would typically do surgery and untwist that bowel. Appendicitis is one of the common things we see in kids. Around 4 to 15 years old is that median age that we see. So the appendicitis is due to that closed loop obstruction of the appendix. It's a lot of times due to fecal material impacted. So people who have constipation are more at risk for having appendicitis because that pressure pushes on the appendix and causes inflammation. If it's not taken care of, you can have perforation, and usually in kids under 2, we see a lot of the perforation. That fecal material is going to cause some peritonitis when that appendix bursts. Surgical emergency, you need to take it out. One of the things that kind of to remember is if a child's having vomiting and diarrhea and then abdominal pain, you might think more of a gastroenteritis. But if the pain comes first, then followed by the vomiting and nausea and vomiting, then you may think more of an appendicitis, especially if they have a pain, what's called the McBurney's point is your right lower quadrant. Also rebound pain. So pushing on it hurts, letting go hurts more. And kids who have appendicitis look really ill. I kind of like to call them toxic. They look so ill. They're pale. And then if that pain is suddenly relieved, then that can be a sign that the appendix is perforating, because now that pressure has been relieved because it has burst open, which is also dangerous because now, like I said, you get the peritonitis. So we talk a little bit about some of the chronic disorders, not all of them. One of the ones I go over in the slides are the ones that you're responsible for. So gastroesophageal reflux, so that's when the gastric contents go up into the esophagus. We see this in the smaller babies. That's why positioning when feeding is really important so that they're not laying flat. Kids who are breastfed typically have less of the GER because of the position of breastfeeding. If it becomes more of a chronic condition, they would name it GERD with a D, because then it becomes the disease. We do see it in the premature infants. And so they can, it can be treated with, conservatively with position changes. Also can be treated with medications. And then also, if there's continued problems, they would do a Nissen fundoplication, and that's where they bring the gastric fundus and they wrap it around the esophagus, and then that prevents the gastric contents from going up into the esophagus. And we do see GER in a lot of kids. A lot of kids are on medications for them. But also, like I said, positioning helps too. Constipation is something we see a lot in kids, especially the, kids, toddlers, preschool, school age, has to do with lack of exercise, poor diets, things like that. Breastfed kids poop more. They should almost poop every time they're fed. Otherwise, if they're bottle fed, they should have it, 1 or 2 times a day. We do enemas for constipation, nutritional training, things like that. Encopresis is when there's soiling, the fecal materials have seeped around the blockage. So kids with chronic constipation, withholding of stool, after a while it gets painful to go poop. And so kids will have sometimes this blockage, and then it'll seem like they're all of a sudden soiling their pants when they've been potty trained, but it's because of that. So typically that requires either manual disimpaction, which we very rarely do in kids, enemas, things like that, maybe giving them Miralax to take every day. If it's severe, we may put in an NG tube and put a formula called Go Lightly, which people take when they're going to have a colonoscopy to clean out the bowel. Kids can't drink it because it tastes like river water. And so they'll put an NG tube in and then slowly instill the Go Lightly in there, and then they'll go. And then at that point, they'll also do the education and nutrition, activity, high fiber foods, things like that. Hirschsprung's disease is a disease in the intestinal tract causing an obstruction. One of the biggest things to think about Hirschsprung's is when babies are born, within 24 hours, they pass what's called meconium stool. It's a sticky, tarry, black stool. If they don't pass that within 24 hours, that's concerning, and they would do some investigation for Hirschsprung's. So they're lacking the ganglion cells, so it's an aganglionosis, and they would have to do a resection of that bowel. There's no other way to do it. If it's down towards the rectum, they will have to do an ostomy. But if it's a little higher up, they can do what's called an end-to-end anastomosis. So they'll cut out the bad part, put the two good parts together, and then taking out that aganglion area. And one of the biggest things with this, when kids have surgery, is forming of scar tissue there sometimes can cause some obstructions. But it's the most common cause of the neonatal intestinal obstruction. Short bowel syndrome. So short bowel syndrome is when you have cut too much of the bowel out. They can be born with short bowel syndrome, but we also can cause it by, having the volvulus and taking part of the bowel out, having intussusception if we have to take that part of the bowel out, Hirschsprung's disease, things like that. Once you start cutting away at part of the bowel, they can have problems with nutrient malabsorption, and then fluid and electrolyte losses. One of the other things that we see that you'll probably learn about in the OB world is necrotizing enterocolitis. So it's an infection that causes bowel to die, and the gastroschisis, which is when they're born with their intestines on the outside of their skin. So usually there's some type of opening at the umbilicus, and the intestines will be outside, and that's a medical emergency also. And those are kind of covered a little bit in the newborn chapter. Kids who have chronic problems with short bowel syndrome are often on TPN for sometimes the rest of their life. They they don't have the digestive enzymes, they don't have that peristalsis, and so they always have nutritional problems. And the only hepatobiliary disorder that we're going to talk about is biliary atresia. So that's an absence of the major biliary ducts. And so this is something that kids are born with. When we think about biliary atresia, it's either absence of some or the major ducts, and it causes an obstruction in that bile flow. So also can cause some cholestasis. So you can see them as jaundiced. One of the biggest signs of biliary atresia is acolic stools, so chalky and white stools, because there's no bile in them. Again, the jaundice you'll see too. How they fix this is they'll do a hepatoportoenterostomy, and they will connect the valve to the bile ducts. Just some of the psychosocial impact with any of the GI disorders that aren't noted in utero. Parents are have a hard time accepting these problems. Short bowel syndrome is one that is a lifelong thing, so that their kids sometimes can't even eat because of that. And then hospitalization is often a problem for parents with any of the diseases. And